Thank you. So my background's actually in obstetrics and gynecology, and I just finished my residency in Edmonton. So I am a gynecologist officially. Our objectives for today are to review female sexual dysfunction, to explore the relationship between female sexual dysfunction and interstitial cystitis, and to discuss some treatment options that are available for these women. So we can't possibly talk about dysfunction unless we know what normal sexual response actually looks like. So, and we can't do that unless we talk about these two people. Does anyone know who this is? Yes. So, William Masters is was a gynecologist who was really interested in human sexual function. And before his time, the only thing that we knew about human sexuality was from case histories, from interviews, and from secondhand data. So what he did was he hired Virginia Johnson as his research assistant. At the time, she was a sociology student, and he did research, human-based research on human sexuality. He was able to recruit 382 women and 312 men and conducted his study over an 11-year period and observed at least 10,000 complete cycles of sexual response. He observed physiological changes using EEGs, ECGs, color cinematography, biochemical studies, and direct observation. And then he released his first book entitled Human Sexual Response in 1966. And this is in kind of a chart form summary of what he found. So what he described was 4 phases to the human sexual response. It starts off as desire, goes to arousal, orgasm, and ends in resolution. So as you can see, the top graph is that of the male sexual response, and the bottom graph is the female sexual response. And this was really the first time that there was exhaustively detailed literature on female biological response to sex. So, and the main difference between men and women was that men had this refractory period before they are able to orgasm or to undergo arousal and orgasm again. Oops, I didn't mean to do that. Whereas females were actually capable of having multiple orgasms. The DSM-4 criteria on sexual dysfunction is based on this linear model where it starts off as desire, goes to arousal, orgasm, and finishes in resolution. So we'll just quickly go through some of that DSM-4 criteria. The first one is hypoactive sexual desire disorder. So this is when you have persistently or recurrently have deficient or absent sexual fantasies and desires for sexual activity. This disturbance has to cause marked distress to the individual or interpersonal difficulty, and this sexual dysfunction is not better accounted for by some other axis 1 disorder or general medical condition or due to a medication effect. So that's hypoactive sexual desire disorder. So after desire is arousal. So sexual arousal disorder, as defined by the DSM-4, is persistent or recurrent inability to attain or to maintain until completion of sexual activity an adequate lubrication, swelling response of sexual excitement. And again, this has to cause distress, and it can't be better described by some other axis 1 disorder, general medical condition, or medication effect. And then there's orgasmic disorder, when you have persistent or recurrent delay in or absence of orgasm following a normal sexual excitement phase. And finally, have sexual pain disorders. And this is divided into 2, dyspareunia and vaginismus. Dyspareunia is when you have recurrent or persistent genital pain associated with sexual intercourse. And vaginismus is when you have recurrent or persistent involuntary spasm of the musculature of the outer third of the vagina. And again, as with every other diagnosis, it has to cause marked distress to the individual or interpersonal issues, and is not better described by some other general medical condition or medication effect. But a lot of research has actually gone into the female sexual response since the time of Masters and Johnson. And evidence is showing that progression, that linear progression that goes from desire to arousal to orgasm and finishes in resolution, actually doesn't apply to most females once they're out of that first initial phase of a relationship. So they found that desire isn't usually the first thing. So at the beginning of any given sexual experience, a woman might not experience desire. It might actually start off with some sort of motivation, and it's generally not some physical motivation. It's usually something psychological or emotional that causes them to want to be instigate sex or to agree to become responsive to sex. So this could be their want of being emotionally intimate with their partner. They want to feel better about themselves. They want more self-esteem, self-image, desire, feel desirable, whatever the case may be. And so when they become willing to become responsive, then they need adequate sexual stimuli in the appropriate context, which is what actually leads to subjective arousal and subsequent responsive sexual desire. So again, women need motivation to become willing to become sexually aroused, and then they need the appropriate stimuli in the appropriate context to actually experience arousal and sexual desire. And so that we call this responsive sexual desire because it's not that spontaneous type of sexual desire. And this leads to sexual satisfaction with or without orgasm. And again, they also get these non-sexual rewards of emotional intimacy, well-being, etc. So that's kind of how the female sexual response cycle operates. So they actually looked at spontaneous desire. It was a study done by Colwood, and they took 50 premenopausal women in a community, and they asked them exactly how often do you actually have a spontaneous sexual thoughts, fantasies, or whatever they may be. Guess how many people reported that they actually have at least one sexual thought a week out of the 50 women? Did someone say 0? That's kind of sad. It's actually 2. 2 women out of 50 said that they actually had more than one sexual thought a week. Guess how many women actually said they had either less than one or never? Less than one or never in a month. Close. No, it's 23. So 23 out of 50 women did not have a sexual thought, had less than one sexual thought a month, or never had sexual thoughts. So according to the DSM-4, a lot of women are abnormal. But again, based on evidence, and this is the newer model of female desire, it may not be that women have spontaneous desire, and that's completely normal. So available evidence suggests that there are problems with the existing definitions of sexual desire, arousal, and orgasmic disorder in women. So an international committee of experts was commissioned and sponsored by the American Foundation of Urologic Disease to take a look at the DSM-4 criteria and actually revise them and change them so that it actually reflects what women's actual sexual response cycle is like. So when we look at hypoactive sexual desire disorder, this has been renamed as sexual desire, interest, and disorder. Oh, and so these recommendations came out in 2003. The DSM-5, which is coming out in May of 2013, will probably reflect a lot of these recommendations that have been listed. So hypoactive sexual desire disorder, again, this is just the DSM-4 criteria. Persistently or recurrently deficient sexual fantasies and desire for sexual activity. Based on this definition, a lot of women would actually be abnormal or dysfunctional. So this has been suggested to be changed to add this lack of responsive desire, and this is going to be the key to the diagnosis of this condition. What about sexual arousal? Well, in the DSM-4 criteria, they talk about adequate lubrication swelling response. Now this is a completely physiological or genital arousal that they're talking about here. So when they look at arousal, there's subjective arousal when you feel or you think you're aroused, and physiological or genital arousal. And in men, the two seem to correlate. When you have genital arousal or an erection, you are subjectively aroused. When you are subjectively aroused, you actually have an erection. But in women, it doesn't seem to be the case. In women, it seems to be that subjective arousal is strongly modulated by thoughts and emotions triggered by the state of sexual excitement. And they actually did a study to look at this. So this is a vaginal photoplasmograph probe. This is inserted vaginally, and this can measure vaginal vasocongestion. So vaginal vasocongestion is a measure of physiologic arousal. So they took normal women who had normal arousal, and they took women who had decreased arousal, and they placed this probe inside and gave them some sort of erotic stimuli in the form of generally pornography. Pardon?
Anxiety condition.
It's a what?
That's the anxiety condition.
I don't know. Movember neurologist, probably not the best. Sorry, I lost my train of thought. So they asked the subjects to rate their subjective arousal, either by a Likert scale or some sort of lever that said, yes, I'm aroused, or no, I'm not aroused. And what they found was really interesting. So despite the fact that the women who have sexual arousal disorder lack the subjective arousal component, the vaginal probe indicated that they actually have normal vasocongestion. Oh, this is going on time. And that's comparable to those controls. So those two things, subjective arousal and genital arousal for women, can be completely separate. So in the new recommendations, arousal disorder has been subcategorized into these different categories. So subjective arousal disorder is when you actually have the normal genital response, but subjectively you don't feel aroused from any type of sexual stimulation. And then conversely, genital sexual arousal is when you're missing that genital arousal component. And then there's the combined genital subjective arousal disorder. And finally, you have the persistent genital arousal disorder, which I don't think much is understood about it, but basically it's spontaneous and intrusive genital arousal in the absence of sexual stimulus, and it doesn't get relieved by orgasm, and it can go on for hours or days. Causes of female sexual dysfunction are definitely multifactorial. It could be interpersonal issues, so emotional relationships with partners during sexual activity, or the individual's actual general emotional well-being. And it could be contextual factors, such as their concerns for safety. Are they at risk for sexually transmitted infections? Are they worried about unwanted pregnancy? Are they feeling safe in this vulnerable environment? And then appropriateness of the location. Is it private enough? And simply situations such as it not being sufficiently erotic for them, it's too hurried, it's too late in the day, whatever it may be, all of these factors play into the causes of female sexual dysfunction. Personal psychological factors also play a huge role into the cause of female sexual dysfunction. So where their self-esteem is, what they see themselves as, their emotional stability or instability, their past negative sexual experiences, as well as expectations of negative outcomes to a sexual experience, such as pain, can all have effects on female sexual dysfunction. And finally, biological causes. So that would be your medical issues that are contributing to female sexual dysfunction, whether that be medication effect or some sort of chronic disease, surgical menopause, radiation, what have you. All of these things can actually contribute to female sexual dysfunction. So why do we care? Because sexual dysfunction has a huge impact on quality of life. And you probably don't need a study for me to tell you that, but I have a study. So this study enrolled 137 patients who were diagnosed with sexual dysfunction based on the DSM-4 criteria. They also enrolled 111 patients as controls that were matched for sex, education, and marital status. This actually is both men and women that were enrolled in this study. 90% of these people were married, 10% were single. And they gave them two questionnaires, a general health questionnaire 28 and the personal well-being index for adults, and the Personal Wellbeing Index measures quality of life in adults. And what they found is what you would probably expect. So those people who have sexual dysfunction, in comparison to the controls, when they looked at the general health questionnaire, in terms of somatic dimension, anxiety and sleeplessness, social dysfunction, and depression, there were significant differences between those that had sexual dysfunction and controls. And they specifically looked at the quality of life questionnaire. Again, there were things that stood out. So when comparing those with sexual dysfunction to those that did not, their perception of their own health, their perception of their achievements, and their perception of personal relationships, as well as a feeling of feeling as part of your community, all of those things were significantly affected in these individuals. So now we're going to go on to talking about female sexual dysfunction in urology. So there was a study that was performed in the U.S. in a major metropolitan city in a female urology clinic. And the aim of the study was to determine the prevalence of female sexual dysfunction in a population of patients receiving care in a practice that focused mainly on female urology. So all female patients that were seen between 2003 to 2006 underwent a modified female sexual function index questionnaire, which is a self-administered questionnaire. And they identified 587 women who completed this questionnaire. And of the 587 women that attended this urology clinic, 63% of them had female sexual dysfunction. That is a huge proportion of women that are attending this clinic. And the age range of these patients are anywhere from 18 to 95. So looking at this graphically, you can see the, where are you going? The female sexual function index looks at 6 components: desire, arousal, lubrication, orgasm, satisfaction, and pain. And you can see the distribution. I mean, you would expect as you age that all of these issues would increase in it, and it certainly does. But just because you're in the 18 to 30 doesn't mean that the prevalence of these issues is low, because you can see that they are quite high, especially when you compare it to the general population. And this is just from a study that looked at a general population of women. It only looked at 3 things: desire, arousal, and orgasm. And this line here describes the desire component. The open triangle here, arousal, and this one here would be orgasm. So, so you can see that there is definitely, in comparison to the previous graph, a disproportionate number of women in these clinics that experience female sexual dysfunction. So let's look at the actual prevalence of sexual dysfunction among patients who have bladder pain syndrome and interstitial cystitis. So this was published in 2011 in Journal of Urology, and the objective of this study was to examine the prevalence and correlates of general and bladder pain syndrome and IC-specific sexual dysfunction among women in the RAND-IC epidemiology study, or the RICE study. So what they did was they screened 146,000 households via telephone to identify women who actually might have bladder pain syndrome or IC, and those women that were identified as being at risk for these conditions were further screened to diagnose them with IC or bladder pain syndrome. And then, and through the study, they were able to identify 469 women who met their criteria of bladder pain syndrome and IC. And of those 1,496 women who met the criteria, they identified 985 women who had a current partner and were sexually active. So then they administered 2 questionnaires to these patients. And one of them was on general sexual dysfunction. The other one was on IC-specific symptoms related to sexual dysfunction. And this was the result. So the domains that they asked, or the questions that they asked, were bladder pain during sex, bladder pain after sex, fear that sex would exacerbate bladder problems, urge to urinate during sex, pain in the genital area, and lack of sensation in the genital area. And what you can notice is there is a high number of women who identified as having, and these are all in percentages, of women who identified as having somewhat of a problem or very much a problem in all of these questions. And when they looked at general sexual symptoms of lack of sexual interest, inability to enjoy sex and relax, difficulty becoming sexually aroused, difficulty having orgasm, and dryness and poor lubrication, again, you can see that there are a lot of women who reported having somewhat of a problem or very much a problem with these issues. So this study concluded that there were 88% of women with IC that reported one or more general sexual dysfunction symptoms, and 90% of women that reported, that's supposed to say one or more IC-specific sexual dysfunction symptom. And when they asked these women if they actually saw anyone for this problem, only a quarter of them sought any medical help. And according to the study, about 8% of women felt that they were actually, after seeking help, received and had their problems resolved. And in terms of this is, I just threw in, just because I think, Dr. Techman, is this done here? Yeah. Was this study done here? Yeah. So I just threw this in because this was a Canadian data and local data. So 97 patients were identified, 75 with newly diagnosed IC, and 22 controls who were sexually active within the past month. And they were diagnosed with IC based on suggestive history, physical exam, urinalysis and culture that were negative urine cytology, outpatient cysto that showed no cancer or foreign body, and voiding diary showing small frequent voids and absence of urinary incontinence or polydipsia with an elevated PUF score. And all of these women were given the Female Sexual Function Index self-administered questionnaire. And what they found, you would think that with interstitial cystitis that the domain that would be affected would be pain. But it's not just pain that's affected in these women. They describe having issues with desire, arousal, lubrication, orgasm, satisfaction, pain, all of the indexes within this self-administered questionnaire. And just a little bit about IC and vulvodynia. Vulvodynia is vulvar discomfort, most often described as burning pain, which occurs in the absence of relevant visible findings or a specific clinically identifiable neurologic disorder. And when they looked at women who had IC and tested them to whether they had vulvodynia, and the test for vulvodynia is when you take a Q-tip and just lightly touch in the posterior fourchette between 5 o'clock and 7 o'clock, and most women would describe a disproportionate amount of pain or burning sensation in that area. 60% of women with IC had vulvodynia, and some of those women also described having levator pain. So a lot of women with IC may also have vulvodynia, which may be contributing to some of their sexual dysfunction. So what can we do? So we can actually screen women. There's a Female Sexual Function Index. It's a 19-item questionnaire that looks at, again, 6 domains: desire, subjective arousal, lubrication, orgasm, satisfaction, and pain. And there is one specific to menopause. Those are the 2 that I found, but they don't, the criticism of both of these screening or questionnaires is that they don't reflect the new recommendations, the new changes to the DSM 5 that should be coming out in May. There are other questionnaires that do reflect these changes, but they're very long. They're about 38-item questionnaires, which probably wouldn't be useful in a clinical setting, though they are being used in a research setting. So treatment. Treatment for these women really depends on the individual, their current situation, their well-being, their interpersonal relationships, their, as we talked about, it depends on a lot of things, and female sexual dysfunction is multifactorial. It's never just one thing causing their dysfunction. And treatment really has to be catered to that individual. They could be treated with physiotherapy, Botox injections, sleep hygiene, cognitive behavioral therapy, sex therapy, couples counseling, medication modification, all of these things, as well as mindful-based CBT, vaginal estrogen, medications. Things can be done for these women, but they really need to be assessed well. They need to be, you need to take a really, really good history. It needs to also involve the partner, and so it takes a lot of time to assess these women and to treat them appropriately. But the great news is you're in Vancouver, and Vancouver is lucky. They have a Center for Sexual Medicine, and this is the website for them. On this website, it actually has a PDF referral form that you can fill out for your patients and refer them on for counseling and for assessment. And they'll get a comprehensive, multidisciplinary approach to their sexual dysfunction. If you identify women who actually have vulvodynia, there is also a multidisciplinary vulvodynia program here at the Diamond Healthcare Center, I believe, which also looks at vulvodynia from all different angles and treats them appropriately. So women in Vancouver are really lucky. We don't have anything like this in Vancouver, or in Edmonton, as far as I could see. So these resources are here for your use. So just a few take-home points. Female sexual dysfunction is highly prevalent among patients with interstitial cystitis, and as well as the urology population in general. It's crucial to ask these patients about sexual dysfunction, because if you don't ask, they're not actually going to seek help. The etiology is multifactorial. Treatment is highly individualized, multidisciplinary, and multimodal, and so refer, because these women need help and they're going to need more than a 15-minute appointment. So those are my references. They went through very quickly, and if you have any questions, I'd be happy to take them.